From yesterday's regular meeting of the Board of County Commissioners, we are resuming our agenda. Today is Wednesday, February 12th. We're going to dive into our work session. Item number 10, our Health and Human Services. We're going to be looking at the Lane Stabilization Center update. We have some experts here at the table. And I think just for the public who's watching, it's maybe prudent if we introduce who's in the room, just so people can know. I'll go ahead and introduce myself and go clockwise around the room. My name is Commissioner David Lovell.
Commissioner Ryan Senega.
Commissioner Heather Buck.
Goda Dilmont.
I'm David Richu. I'm the Medical Director for Lane County Behavioral Health.
Brittany DeLiso with Lane County.
I'm Margie Balfour. I'm a visitor from Connections Health Solutions.
Eve Gray, Director of Health and Human Services.
Lori Trieger, Lane County Commissioner.
Real loud back here in the back.
I'm Courtney Sanchez, Director of Business Development for Connections.
I'm Ryan Johnson, Senior Business Development Associate with Connections.
And I'm Linda Studer-Ells. I'm a Senior Director on the implementation team for Connections.
Great, thank you very much. This is a presentation that I believe Brittany DeLiso, our Behavioral Health Project Manager for Lane County Health and Human Services, and is Dr. Margie Balfour going to be joining us?
Right here.
Oh, that's you right there. Well, my apologies. Dr. Margie Balfour is also here, the Chief of Quality and Clinical Innovation for Connections Health Services. And Courtney has obviously introduced herself, so has Ryan and the rest of the team. So I welcome you all, and whoever wants to start leading us off, please do.
Yeah, I was going to introduce Dr. Balfour, but you just did, so I think we can probably hand it over.
Okay. So, and thank you all for having me. I was telling some of my friends I'm considering this my first trip to Oregon because I had to take my oral boards in Portland like 10 years ago, and so I only went to the State Hospital and the Marriott, so I don't count that as a visit to Oregon, but it's lovely so far.
Well, technically, if you spend the night in the state, you can count it, so yeah, good for you.
But I'm happy to be in Eugene. So I'm going to be talking about crisis systems and what's going on nationally, and also what what we do at Connections and how that might apply to what y'all have got going on in Lane County. So up until just very recently, there have not been national standards for the sorts of services that we're talking about. Like for medical emergencies, you know what to expect. It's just ingrained. You pick up the phone, you call 911, an ambulance comes, they take you to a hospital. There's level 1 trauma centers, level 2 trauma centers. That's just sort of, we expect that. We don't even think about it. It's just expected that it's going to happen. But we don't have that for crisis behavioral health emergencies. And why is that? There's a few reasons. One is crisis services have really flown under the radar because partially of how they're funded. So they're mostly funded by either Medicaid funds or local funds, like county funds, which there's an old saying that if you've seen one state behavioral health system, you've seen one state behavioral health system. Even further, you go into a state, you've seen one county behavioral health system, you've seen one county behavioral health system. So there hasn't been like an overarching kind of federal unifying framework because it's all been done at the state level. There haven't been standard definitions for what the services even are. So up until literally just 3 weeks ago, if you said the word crisis stabilization unit, there wasn't a standard for what that means. So in one place, it might look like something totally different, in what it might look like somewhere else. And then, stigma, prejudice, we expect this level of response for medical emergencies, but behavioral health emergencies have always sort of been something, where, well, if there's some extra money, we can fund stuff. It just hasn't been at the forefront like we expect for medical emergencies. But luckily, things are changing. So SAMHSA, who is the Substance Abuse and Mental Health Services Administration, that's the federal agency that gives money to the states to fund a lot of their mental health services, and that usually trickles down to the county level or local, whatever your local behavioral health authority level is. They've put forth a vision where you have something akin to what medical emergencies get. So, currently what most communities in America have is you call 911, and like I was saying, if you've got a medical emergency, there's this whole response that we're used to having, and clinicians arrive on an ambulance and get you what you need and take you to an ER. But if you have a behavioral health emergency, most likely that 911 call goes to the police, and then you're basically setting up a system to have, not the ideal outcomes. You're sending police officers to what's really a health emergency. That puts people at risk for, officer-involved shootings. It puts people at risk for being taken to jail. So what SAMHSA has envisioned is something akin to what we have for medical emergencies, where, and they've arranged it into 3 pillars. There's someone to contact, and that's the 988 number, which has gone live across the nation back in July of 2022. So that's a 3-digit number anybody can call. Just recently, they've fixed it, so now they know what cell phone tower your call comes from, so they can route it to your local 988 call center. And then there you get people who can address your crisis, that everyone has someone to respond, and that's mobile crisis. So similarly to how the medical emergency and ambulance with clinical people on it responds, this would be a response with behavioral health clinicians to respond to you out in the field, wherever you are, in your house, on the street, etc. And then finally, that 3rd pillar is a safe place to help, where just like we have emergency rooms and level 1 and level 2 trauma centers and all these things for medical emergencies, you have facilities that are specialized and able to care for people who have behavioral health, mental health, and substance use related emergencies. I was, in the lead up to trying to get some standards around this, the National Council for Mental Wellbeing put out a report called the Roadmap to the Ideal Crisis System that talks about what these 3 pillars and components should look like. Also talks about some of the services that you should have after the crisis to make sure that people get connected back out into the community. And in that report, and this came out in 2020, in this report, as a precursor to what SAMHSA was doing, it really makes a statement, and back then this was kind of a bold statement, that a behavioral health crisis system is an essential community service, just like police and fire and EMS, and that we should have that same expectation, but also laid out the concept that it's not just those individual services that we're talking about, it's a whole system of care. Just like the trauma system, there's a whole system about how, which ambulances go to which hospitals and which hospitals have this type of service and whatnot. You need a coordinated system for crisis care as well. And so we actually, in that report, I was part of the group that put that together, we talk about the whole accountability and finance and governance mechanism that is the base of that pyramid that then you layer the services on top of, so that you have a structure to have a system that works for everyone, that's coordinated, and that's sustainable. SAMHSA then, recently, and I literally it came out January 15th or something. It was a week before the inauguration, so I mean, brand hot off the presses. Put out finally a set of standard definitions for what all these services are. What is a crisis stabilization center, and then kind of how in the medical world you have a level 1 trauma center where the really bad accidents go, and then you have a level 2 that's a step down, and then you have different levels, and then you have different types of mobile response, things like that. Finally, there's now national definitions for what those different services are. And along with that, an updated set of guidelines that incorporates a lot of those concepts that are in the roadmap around how you need a whole system that's working together, and you need to look at your whole community and figure out what services that community needs and how to coordinate them. And I was on the work group that put those together, and a big part of that work was not only having those definitions just for system planning and for clinical care, and to be able to have standards for that, but also to lay the foundation for how to pay for these things and for parity reimbursement. One of the reasons why insurance companies have not paid for this is we don't even have a definition for what it is. So and certain types of services cost more or less than other types because they're treating different levels. One is treating the really bad accident victim, and one is treating someone who broke their arm. It's different levels, and there haven't been ways to articulate the difference in that and how to assign costs to that. So these guidelines are a really important step in moving the whole crisis system forward. Here's an example, and I'll talk about a coordinated system, what that might look like. This is, for historical reasons, don't want to get into, but certainly can if you have questions. Arizona's been working on its crisis system for decades because there was a lawsuit, and then there was a lot of investment in crisis services, and so over the course of 20 or 30 years, Arizona's really been building its crisis system, and so it's often looked at as a model. This is data from Southern Arizona, from Tucson, which is where I am in the crisis center that when I first joined Connections, ran directly is. And this shows what we mean by a coordinated system. And part of that coordination is that everyone is working towards common goals. And the common goals for crisis care are that you want people to get care in what we call the least restrictive setting, or sometimes the flip of that is the most community integrated setting. So if possible, you want to keep people out of jails and emergency rooms and being locked up involuntarily in hospitals if they don't need to be. And so that least restrictive is kind of the clinical goal. But also these least restrictive settings, more community-based settings, are less expensive to pay for than the more restrictive settings. And so so they're least costly. So, one of the great things about crisis services is whether you're coming at it from a clinical standpoint, a social justice standpoint, or a responsible stewardship taxpayer fund standpoint, it makes sense. And here's sort of an example of how that all works together. So the least restrictive thing is to be able to pick up your phone and ask for help, and when you're out in the community. And so that's where the crisis line or crisis contact centers, which is now 988, come into place. So in Pima County, my county, the crisis line gets about 6,000 calls a month. In addition, they get texts and chats too. And they're able to resolve the vast majority of those on the phone. It's actually above 80%. This is a little bit older data, but well over 85%. They're able to resolve those by either doing telephonic counseling, but also because the system's coordinated, they have access to a system to make people appointments. So if 2 in the morning, part of what can resolve your crisis is knowing that you have an appointment tomorrow at 11:30 at the clinic at this address. They're able to do that as well. For people who need a higher level of intervention, then they dispatch our mobile crisis teams. So Pima County, which is about 1 million people, has I think 12 to 16 mobile crisis teams that are two-person teams. They're clinical teams, so not law enforcement teams. It's either 2 clinicians or a clinician and a peer, and they're able to respond to people out in the field, wherever they are, the street, the washes, at their house. And when they do a face-to-face intervention, they resolve about 70% of the crises from that in the field. For people who need a still higher level, then we have our acute crisis facilities, of which we are the largest in the area. There's a smaller one that does mostly detox also. And these facilities are meant to be places where mobile teams can drop someone off, where anybody can walk in, where police can drop people off, and have a combination of urgent care, which is sort of just see someone and then you're good to go, versus staying overnight, and then some people can stay longer for a few days. And the vast majority of those folks, 60 to 70%, end up being discharged back out to the community without having to go on for a hospital stay. And then your crisis doesn't just flip off like a light switch, and so there's services to help people make that transition back out into the community. There's some post-crisis wraparounds. There's like a peer-run agency that follows people for a few weeks after, make sure they make their appointments, make sure they get their needs met, get transportation, things like that. Working with those social drivers of health. There's also some lower acuity crisis facilities like crisis residential, crisis respite. These are in the new SAMHSA parlance called moderate intensity or medium intensity residential services. And people can step down to there to further stabilize, further work on some of the social needs like working on housing and things like that as their crisis resolves.
Dr. Balfour, would you mind, excuse me for the interruption, would you mind if there are some questions along the way, or would you rather just, okay, you're rolling really great, and you got a lot of information, but sometimes we have some questions come up. I'm wondering if we could interrupt.
Sure.
How about now?
Yeah.
Okay.
Thank you. This is really quick just to track. I think you said 6,000 calls a month. Is that countywide?
That's for the
And you're a
county.
county of about 1 million, so we're about a generous third the size. Do we know what our numbers into 988 for our county are? Or do we not know that right now?
I don't have those numbers specifically, and we're maybe a little less coordinated because 988 is a Portland-based number. We also receive calls into our local crisis line that we are required to run, and there are still a number of calls that go to 911. So it is still hard for us to parse it out in this type of data.
Okay.
Yeah, and in Arizona, we actually moved. We used to have a crisis line for each region of the state, the north, the south, the south. And when 988 went live, there's a single statewide line, but they're able to tell which area they come from via either. There's an old number that people call, like, I don't want to get into all the details, but there's ways that they can tell, like, where those calls came
Great.
from.
And I get it's a tricky thing, right? Because you can see increased numbers of calls as a good thing, as in more people know that resource is available, or as a sign that there's an increase in people in distress. It's hard to know which.
Yes.
So I was just asking
Yeah.
just to get some.
And it is, like, when
point
you're
of
interpreting this,
Yeah.
like, that's a very good point, because when you get into this, like, all crisis utilization is bad, and it's like, well, like, but if they're going to crisis care instead of the emergency room or jail, that's good.
Right.
And so it's really like the complexity of interpreting this stuff.
Yeah.
It's good to be thinking like more, layered like that.
Yeah, thank you.
To follow up to Commissioner Trigger's question, I mean, algebra was my favorite topic in high school, sorry. Running through those numbers that you said, and us being a third the size of 1 million county, that in my quick math, that means about 38 folks a year, according to that formula, would be in a community residential care facility from Lane County if those numbers held up consistent with Lane County.
That's, like, that would be like if everyone went that pathway, but as I'm gonna show later, you can get into the facility through different routes. So this is just like, if you were to call mobile crisis and then the mobile crisis team came and then you went to the facility, but people can walk in.
Right.
And then the police bring a huge chunk of our volume.
Okay, good. Thank you. Continue. Good job.
So, and so to that point, one of the goals of the crisis system is to decrease people who need behavioral health treatment from ending up in the justice system. And if you're familiar with the sequential intercept model, basically it's a model that says there's a pathway that people follow through the criminal justice system. There's some kind of police contact, then there's an arrest, then you get booked into jail and so forth. And at every point along there, there's an opportunity for the mental health system to intercept that person and get them into treatment and keep them from going further in the justice system. And so it used to start with Intercept 1, which is the point of police contact. And then based on work in Pima County, they went backwards and added Intercept 0 because it was recognized that if you have a really robust crisis system, you can prevent the law enforcement interaction altogether. And so that's why in the system it's designed to have easy access for law enforcement. I like to say, like now there's all these movements to train law enforcement with like crisis intervention training, and you're teaching them to recognize crisis, and then you're telling them to divert them to treatment. And so then it's on us to make it easy for them to do the right thing and have really easy access. That's why sometimes we sort of talk about law enforcement as a quote preferred customer, because that gets, you want to clear the pathway for them to get them into the crisis system. So starting as upstream as possible at the point of 911, because people are always going to call 911. And what they've done is crisis line staff are co-located over in the 911 communications centers. They're employed by the crisis line, but they're in 911 communications. They have full access to the dispatch system. They're totally plugged in, and they are able, and they're there 24/7, and they are able to intercept about 1,000 calls a month. And so these calls then go that complete clinical pathway, and there's never a law enforcement response. The mobile crisis teams, there's things kind of baked into their contracts to prioritize law enforcement calls. So for example, if I'm at my house and I call 988 and they want to send a mobile crisis team to me because I'm in crisis, their contract says they're supposed to get to me within an hour. But if I'm a law enforcement officer and I'm out in the field and I've got a civil commitment order and I'm knocking on someone's door to bring them in because they're suicidal, for example, and the person says, I'm not coming out, and they need mobile crisis to come help them, they have a half hour to get to them. So like these incentives are baked in to prioritize that when law enforcement needs help. And then the crisis facilities, and I'll talk about this in more detail, but they are really set up to make it faster and easier for police to bring people there than to jail. So, and one of the main ways we do that is by having a very quick drop-off. It's usually less than 10 minutes. And by never turning them away, because once you turn them away once, they're like, oh, those people, they won't take my people, I'm just go to jail. So never turning them away is a big deal. So you can see all these different decisions all kind of have this collective impact on these common outcomes of the little Zoom boxes right in front of it. But it says decrease emergency room and jail and hospital use. So as far as what we do, where do we fit in this? Or, where the kind of crisis facilities that we do. And our goal is to provide immediate access to care for people who come to us a variety of ways and of any acuity level. So people can come to us, and this is what I was getting at before, so they don't all go through that pathway with the numbers. Many do. We get about half of our observation patients come via law enforcement. And then about 10 to 15% come, or about 15% come via mobile crisis. Get another 10% who come transferred from emergency rooms, and then the rest are walk-in in our Tucson facility. And so people can come all these different ways. We recently opened a facility in Washington State, and there, the way the laws are, it's much easier for EMS to drop people off. So we get actually more EMS drop-offs up there than law enforcement. That's because most states haven't made it where EMS gets paid the same, whether they drop off at a crisis center versus an emergency room. And I mentioned transfers from ERs, people brought by family, et cetera. And then I have, if you're a Harry Potter fan, like a sorting hat. Because we don't want people to have to go, oh, wait, I have to go there because I'm like, if you see those billboards, it's like, it's like the bee sting, it's like urgent care, and then like the whole beehive of people, that's like the emergency room, like what's an emergency versus what's like urgent care. We don't want people to have to, or police or anybody trying to going like, well, is this like a serious enough crisis to go here, or do I need to take the person here? Our philosophy is like, we'll just take everybody and let us sort it out. And then within our walls, we have different levels of care. So some people, they just, they have the equivalent of the sore throat. They just need to see someone in urgent care, where they can see a social worker, they can see a psychiatrist. If they need a med refill, they're new to town, they need to be connected to services, or they ran out of meds and can't get in to see someone, that kind of thing. And that's kind of one and done. They're, out usually, the median time that someone's in and out is about 2 hours. For people that need some ongoing care, either they came to our clinic and then we try to get them in to see someone in the outpatient system and it's going to take like 6 weeks, they can come back to us and we can bridge them. Or people who come out of our more acute crisis services that need some bridging until they get stable enough to be really handed off to whoever their outpatient provider is going to be. So we can do that in our bridge clinic. And then for the high acuity people, we have our 24-hour observation unit. So this is akin to like a psychiatric emergency room. So, and I'll have some slides with some more detail on that. But these are people who pretty much meet the medical criteria for going to an inpatient hospital. But our philosophy is that a lot of people, if we really start treatment early and aggressively, that we can stabilize them without needing to go to the hospital. It's kind of akin to like back in the day, if you had chest pain, you went to the ER, they would admit everybody to the hospital to make sure to see if you're having a heart attack. Now they don't admit those folks. They keep you in observation overnight, and they've been able to see that most people actually aren't having a heart attack. And then they keep you in observation, and then you're able to go home. So it's sort of similar to that, but for behavioral health. And then for people that need to stay longer, we have our crisis stabilization unit, where people typically stay like another 3 to 5 days in those crisis beds. And as I was saying before, at the end of all of this, most people are able to be discharged back out to community-based care. We also take both voluntary and involuntary. I know every place's civil commitment is different, but one of our, we believe that even the involuntary patients, if you start that engagement and treatment early, that many of them can be engaged and improve to the point where they continue on their care on a voluntary basis, which is less restrictive, and they're more engaged in their care. And then we look at satisfaction, and most will recommend, even though some of them are brought against their will, most people recommend that they would recommend us to friends or family. So the quick and easy access for law enforcement, so that's a big part of kind of who we are, and our mission is to make that whole thing where we want our people in care instead of in the justice system, and the people who have our people are the police, so we want to make it easy for them. This is at the Crisis Response Center. Having a separate entrance for them is really important for a variety of reasons. One, it's easy to get in and out. So they've got like their own secure area where there's a sally port. They buzz a button, it opens, and then we let them through, it's secure. And then they've got their own entrance where they bring the person. Our team is there, waiting to meet them, to get them in and out as quick as possible. Having that dedicated entrance helps make that process work smoothly, but also things like we've got a little office for them because they may have paperwork that they need to do, they need to use the restroom, they need to make a copy, whatever. And if they're walking around the facility and, then our staff is hassling them going, you can't have guns in the clinical area. I don't know if you ever ask an officer to take their guns off, but they don't like it. So, we've got all that they need right back there. You've got a Keurig, we have donuts on National Donut Day. So they like it. And also, too, and this is something that the officers have told us, that some of the other places where they bring people, where they have to go through the main entrance, they're having to walk, with the person in handcuffs, like through the waiting room, and it's awkward, and everyone's looking at the person, and it's stigmatizing for the person, and it's awkward for the officers. They don't like it either. So this way, none of the other patients know like how you got there, whether you walked in, mobile crisis brought you, whether police brought you. So that's another benefit of having that dedicated entrance. And this just shows some of the numbers. The purple is youth, and then the green are our adults. And some of them come on an involuntary basis. And the Tucson police, they do a whole lot of mental health training. I could talk a whole nother hour on them. But they bring a lot of people on a voluntary basis because they've really bought into this model, and they can engage with people and offer them a ride, and people will come with them voluntarily. And then the circles are the median officer wait time in minutes. So you're seeing most of the time it's 5 minutes or less. And we measure from when the officer arrives to when we tell them they can go. And some of them may stick around to, have some donuts and whatnot, but we don't count that time. But that's the time that we allow them to go.
It's not part of the survey.
Yeah. This is sort of the heart of the operation is the 23-hour observation unit, and this in the new SAMHSA parlance would be a high-intensity behavioral health emergency center. We use that word emergency strategically because we want there to be parity with what you expect for physical health in terms of both payment, but also the type of service where you take everyone. That's one thing I didn't mention as much. So we also never turn officers away. So we take everyone. Many crisis centers or what now SAMHSA has a definition for what is called medium intensity, where they can only be voluntary or they can't be too violent or agitated. And we want those people. We want the high acuity people because if we were to say no to them, they'd end up in a hospital or emergency room, which is not a good place for them. Whereas we believe that those are the patients who are most in need of specialized care, and we have the facility, we have the physical plant, the layout, the staff, and the training to be able to de-escalate those folks and get them the care that they need rather than just having them wait in an emergency room. And we also do this without security. So that's another, there's, some of the conventional wisdom is, well, if you're taking those really difficult people, you have to have security. Well, we have an interdisciplinary team, and one of the most important members on that team is our behavioral health techs who get tons and tons of training on de-escalation. We look at video to always try to be learning from what we're doing and always improving. We have our peer supports who are people with lived experience and who are able to engage with people. And then we have the rest of our staff. We have nurses, a lot of people on detox protocols, so they're administering medications. We've got psychiatrists. We've got our social workers and case managers working with clinics and families and trying to figure out where that person needs to be stable. So with all of that staff, we would much rather spend our resources on clinical staff rather than default to a security guard who has less behavioral health training. So that's how we're able to do that without security. I mean, they're like in the parking lot and stuff, or just like normal business stuff, but like any business would have, some kind of security that way, but like on the clinical units, there's no security. And you'll see that that's an open, this is our newest, or second newest now, unit that's up in Kirkland, Washington, north of Seattle. And you'll see it's an open area. The reason why it's open, there's a few reasons. One is for safety. If these are people who are, the criteria to be an OBS unit is danger to self, danger to others, psychotic, agitated, intoxicated. And if they're potentially dangerous, the way you keep people safe is to observe them. And so it's an open area so all of the staff can have line of sight on everyone. Also, because it creates what we call in mental health a therapeutic milieu. If you compare to what happens if you go to an emergency room, where if you're suicidal, they put you in a room by yourself, they take all your stuff away, they hire a sitter to just sort of sit there and watch you but not talk to you, and then for 12 hours you wait to be sent somewhere else in isolation. That's not very therapeutic. Whereas here, people can walk around, there's activities, there's groups going on. There's there's interaction between staff and patients, patient and patients also. And then the flexibility. So we never say no, like we're sort of like an emergency room where we're never closed. So we never say no to like the police and mobile crisis and, emergency rooms and things like that. So we're able, having that open area gives us some flexibility to have a surge in volume and then come back down versus if it was all these rooms with walls and stuff. Also, I keep saying behavioral health, and I put this slide in here to remind myself, because I'm so used to thinking of mental health and substance use, they go together, but in many places they're still considered separate. These things go together, so we need to be able to address both mental health and substance use needs. This is data from our Tucson facility where 15% of the people coming in, or when we ask them, like, what's your primary reason for being here? And they'll say, I'm here for substance use treatment. But if you look at our toxicology results and our diagnoses, it's like 2/3 have a substance use issue. And for us, in that part of the country, it's mostly meth. It's hiding that, but like meth is like 50% of all the substance use that we see, followed by alcohol, which is 24%. Although the opiates may be underrepresented because up until recently, we couldn't test for fentanyl. And so, so we can start medication-assisted treatment, and we can start Suboxone, we do detox. We have many of our peers have a substance use history who are able to do motivational interviewing and engage with people that way and try to get them into treatment. And then, and I'll let my teammates here who have been in the weeds more than me answer any questions about this, but this is what we've been talking about for Lane County, which is basically all of the services that you see. And I didn't mention it much, but our Tucson facility does have youth, and so we do these services for youth as well. And then the one that we just opened in Harrisburg, Pennsylvania has adolescents. So, we do very similar things for youth, where the system of care that you're connecting to is different, but the concept of having both the urgent care and the overnight observation is the same. And so then just sort of thinking from a systems standpoint, all these different pieces of the crisis system, where you want to go, I think, is what I call a high resolution crisis system. And if you're nerdy like me, I'm using Mario as my analogy, but because we do the very high acuity crisis center. We're seeing places where they're building like a more low acuity crisis center. And my question is always like, well, where are the high acuity people gonna go? And if the answer is still, they still have to go to the emergency room and like wait to go to the state hospital. I'm like, well, that's, from a systems planning point, your sickest people, you've excluded from your beautiful new crisis system. And so, but not everybody needs that high level of care though. So it's you do want a lower acuity one, to step people down to ultimately, but who are you going to start with? You want to start with the sickest people? It's more of a community decision on how you approach that, but like ultimately, it's not one size fits all. You want, and the SAMHSA guidelines now have all these different levels of care, and they all have a place. So if you don't have a level of care, then your disposition is always going to default to the higher level of care. So like if you don't have a crisis center that can take these high acuity people, then those people are going to go to the ER or jail. And then if you've got someone who's in 23-hour observation that we've gotten better, but they're not better enough to discharge back out to the community, if you don't have a crisis stabilization unit where you can keep them longer in that crisis setting, then you're going to have to send them to an inpatient bed. So the more levels of care that you have, the better you can match the service to what that person actually needs. And I sort of liken it to Mario here, where like, that's like OG Mario from Donkey Kong. He's like made out of like 8 pixels and you can barely tell it's Mario. Versus Nintendo 64 Mario with all these pixels, where it's much more fine resolution of matching that person to what they need. And I may be biased because that's what we do, but and I really, my passion is for the highest acuity patients that oftentimes nobody wants. But you need a crisis center. Like you want all those different levels of care. You want Nintendo 64 Mario, but you have to have one that's going to take everybody. Because if our first responders out there, their options are jail and the emergency room. And, we've talked, I think y'all have been working on this for a long time, so you're aware of why jail and the ER are not good. So, what in the new SAMHSA language is high-intensity emergency behavioral health centers. And then there's also hospital-based, so like what are sometimes called empath units that are attached to an ED. It's the exact same thing, but just attached to an emergency room. Which is what we just talked about. When you have that, then you can keep folks out of emergency rooms and jails, but if you have a crisis center that won't take those people, then that's where they're going to end up. This is just a research study that we recently did. We published it last year, where we looked at, what is the impact of having a crisis system? I was saying Arizona's had a crisis system for a very long time that has mobile and has facilities, and so we looked. We took a bunch of and in Arizona, just because the way things are paid for, no matter what your payer is, whether you have private insurance or you're uninsured or whatever, there's a Medicaid claim for every crisis encounter. And so we were able to use those to construct episodes. So like where you start in mobile crisis, then you go to a crisis facility, or you start in an emergency room and you go to inpatient. So we constructed these episodes of people going through the crisis system. There's like 41,000 of them. And what we saw was that when people were having behavioral health emergencies, most of them began in a crisis service. So we don't have phones on here, but most people started their emergency crisis episode in either mobile crisis or a crisis facility rather than going to the ER and inpatient. And then of those who started off in the crisis system, most of them, 69%, remained in the crisis system. So we weren't sending them off to hospitals and things. And then we looked for the ones that went through our center in Tucson, because we had all of their electronic medical record data so that we could match it. So we looked at that subset of about 9,000 patients to see what happened to them after the crisis. And so to see if they reutilized crisis services within 30 days. So most of them didn't. So after we were finished with them in our crisis center, 63% did not reutilize more crisis services within that 30 days. But of those that did, and this gets to the point that you were making, of those that did have to reutilize crisis services, 73% of them reutilized again in the crisis system, meaning mobile or facilities, and not the ER and hospitals. So, you always hear people talk about reutilization as a bad thing, but I think that's a good thing. People ask for help, they ask for help again in that same system, and it keeps people out of the ERs and out of jails. We also looked at factors that predict reutilization, so not surprisingly. So everything on the right side of the line was more likely to reutilize. So homelessness, black race, stimulant use, and psychosis, which to us is that's a lot of meth in our world. And also the involuntary. So there's kind of a debate as to whether crisis centers should take voluntary or involuntary. The new SAMHSA guidelines say that those high acuity emergency centers should be able to take involuntary. In our data, we looked at people who come in involuntary and then what happened to them. And 60% of our involuntary patients we were able to convert to voluntary during their crisis stay. And then those who were in, whether they stayed involuntary or they converted to voluntary, that involuntary population was less likely to reutilize in 30 days. So showing that we were able to address the crisis of that population. And then we're currently working on some more, we're doing a follow-up where we want to put costs to those numbers. And then if you're interested in crisis measures, so the same group that worked on the roadmap to the ideal crisis system, I'm part of that group as well. And we have a follow-up, a much shorter companion document that talks about quality measurement and outcome measurement in crisis services. So there's QR codes and links if you want to take a look at that. And then also, so it's my favorite, it's true. Also, our co-founder, Dr. Carson, and I wrote, and I was a co-editor of a whole issue on crisis services from psychiatric clinics, but so there's a lot of really great articles in there. And one of them is by myself and our co-founder, Dr. Carson, where we really explain the rationale and the background behind this high acuity crisis facility model. So there's a link to that there as well.
With that pause, I assume you are finished. Thank you, Dr. Balfour. Very, very well done. We are at time, but we do have some time for some questions. So I would open it up to the board or anyone else. And if you have questions for the staff, I would invite you to come to the table. That way we can make sure we hear you recording. So if there's any questions for Dr. Balfour, now's a good time.
Commissioner Farr.
Commissioner Farr, sorry. Thank you.
Thank you, Chair. Dr. Balfour, I regret sincerely that I'm not there to meet you in person. I feel like I know you, having read so much of your work and witnessed some of the successes that you've engaged in and experienced. 9 years ago, almost to the day, I was in Tucson and had a chance to visit the Pima County facility when a family member, a youth, was transported there by the Tucson Police Department. My son and his husband got their advanced degrees from Arizona, University of Arizona, and from Arizona State, the Tucson campus. So I'm pretty familiar with your operation. We didn't talk much about youth today, and this is probably not the exact time to be talking about how your facilities not integrate, but keep the youth and the adults separate, but you provide a similar type of service. Is that, did I observe that correctly? 9
Yes.
years ago, and is that still the case?
Yes, so our building has, because you don't want the youth and the adults to mix at all, so there's like a common kind of atrium, and then as soon as you come in, youth is on one side of the building and adults is on the other side. And so we have the same services, we have the same urgent care for youth as we have for adults, so anyone can walk in, families can bring people in. Oftentimes schools, like schools will say, oh, they can't come back unless they've had an evaluation. So we get a lot of those folks as well. So they see one of our case managers, and then one of our providers. We always psychiatrist, nurse practitioner, PA, and then so a large percentage get their crisis resolved just in that urgent care setting. And then for those who need to stay longer, we have the 23-hour observation, which is exactly like the adults, except the treatment there is a little bit different because kids are not little adults. So there's a lot more activity going, because a lot of the adults, they're like withdrawing from substances and they just kind of want to rest and sleep, where kids, they're always active. So the peers spend a lot of time on the youth units, and there's a structure, there's a schedule to what's going on there. There's an outdoor little patio area too, which is really nice. And you've also got, we've got older kids, younger kids. You have to make sure you keep them separate as much as possible. And then what we don't have in the Tucson facility, because we sort of inherited the building when we were brought in. We were brought in like a few years after it opened, and there's not that longer term crisis stabilization on the youth side. And in retrospect, like I said, we inherited it, but having that longer term crisis stabilization or some kind of longer term crisis option beyond that 23 hours is really important. And we have that in our Harrisburg facility, because the thing with youth is we can resolve the youth crisis in 23 hours. Like that's, they come in, they're agitated, they acted out in a group home, or a lot of our kids are in CPS custody, and they've acted out in their placement. And then we're able to, de-escalate and get them calm, and to the point where they could go back to a placement, either home or wherever they're at before. But the family crisis with youth, you're not just treating the youth, you're treating the family unit, and the family crisis takes longer than 23 hours typically, because we'll be like, oh well, they're fine now, they're good to come home. Oh no, they can't come back home, because that family is still in crisis. And so there used to be another agency in town that had a sort of one of these medium intensity kind of crisis residentials that we could we often would step kids down to, and then that closed for a variety of different reasons. But that was really great when we had that. There's also used to be the ability to place into therapeutic foster care as a crisis placement, but there's some payment issue at the national level that there was a law that got passed that accidentally broke that, and I know NAMI is advocating for some fixes to that. But long story short is that youth works much better when you have that longer term option beyond the 23 hours, and that's why we built that into our Harrisburg. And then what we're doing here, we would recommend doing that too.
And Dr. Balfour, thank you for that answer. I'm sort of cross tracks on this very, very short meeting that we have with you today. I have the extensive notes from our November 1st, 2023 meeting, where Dr. Ratu said the glaring need in our community is youth. And I hold dearly onto that, because we do experience it on a regular basis. Thank you for your work. I'm excited to visit your Kirkland facility. But Chair, once again, I apologize for crossing tracks, but I think the two, both youth and adults, are completely interrelated, particularly when the family is involved, as you say, Dr. Balfour. Thank you.
And nothing has changed since I said that in 2023.
And I will say, youth is difficult to do as a standalone, just because of the staffing, the fluctuations, like there's a lot, wide fluctuations in volume, like between the different times of day and then different times of the year. Like, when they're having testing, like we need a bajillion kids. During the holidays, it's really low. During the summer, it's really low. So just operationally, having like we have our adult side and we have our youth side, but we have staff that live on both sides, because there's people that like youth is their passion and there's people that adults are their passion. But our staff are cross-trained. So when there's these surges and lulls, we can move people around, and that operationally helps make that sustainable.
That is marvelous. Thank you for the time, Dr. Balfour. I look forward to personally meeting you one day soon, I hope.
Yeah.
Thank you.
Cool. Thank you.
Good deal. I don't want to cut us short. I know this is a lot of important information, so if you have any more questions, go ahead.
Well, I just want to appreciate we've been working on this for a long time. I've been a strong advocate for the program, but every time somebody else comes, particularly from Connections, I learn new ways to talk about it that I think are helpful. And just something, when we first started down this path, I remember talking to our administrator, to Steve Moker-Heisky, about, we were calling it the crisis center. And I feel like that was elevating people's anxiety about it because they're picturing the problem, because the problem is the crisis. But when we talk about it as a stabilization center, we're talking about it as the solution that it's bringing. And so I think that's really important language. I don't know how much you've found that to be true. But I really appreciated especially some of the examples you gave of, like the equivalent of a sore throat versus a full-blown, suicidal or what have you. And that the crisis isn't always about, it's a time issue sometimes. It's not always the acuity or the ability for one to have predictable behavior, right? And so that just some of those little nuggets that you drop throughout your presentation were just so important, I think, for us when we're being asked what's the county working on and we want to talk about this initiative, that it's a way to talk about it that's just much more relatable as to the breadth of the issues that it would address and who will be helped. And that idea of reutilization, of not demonizing that. It's like, I've been to urgent care more than once, and they were all for reasons that I would otherwise have gone to an emergency room and waited longer and kept other people from getting care quickly. And like, nobody says you shouldn't have gone there for those 3 different things over a period of 2 years. It's just such an important frame, so thank you for that.
It always helps me to make the analogy to what would happen with the medical emergency.
Yes.
Because everyone accepts that these things exist for medical emergencies and that insurance should pay for it and that the system should be there and that, it should be 24/7 and that's just acceptable. Yeah. So like making that analogy is always
and that it's not, the most visible crisis people are thinking of course, is we see people who are unhoused in the community, behaving unpredictably. Yes, those folks will get the care and they need it and deserve it, but that's not the totality, so bringing it into that. So my one actual question is the issue of the reimbursement for transportation and jurisdictionally, who owns that? And this might be a question as much for Eve as for you, but maybe any lessons you learned that would help us. But where are we with that? Because I know that's been a challenge for us, is who can transport to a facility like this and get paid for it?
Yes. In Oregon, the law is that EMS can only be paid for delivering someone to the emergency department. That is in state statute. So that is a state lobbying opportunity for us.
And then beyond so in many states, that's still the case. Some states have changed the law that allows them to go to, in the terms it's always used as alternative destination. But then, so once you've passed that hurdle, the next hurdle is reimbursement. Because in most states that allow that alternative destination, including Arizona, they can get reimbursed, but it's less.
Yeah.
So what Washington did is they passed a law where they get the same reimbursement. CMS had a demonstration project called ET3. It was Emergency Triage and Transport, where communities could apply to be part of the demonstration where they would get parity reimbursement. And they ended that early for, quote, lack of participation. But I think the timing was off because the alternative destinations are only just now being built, right? Most communities didn't have an alternative destination, so like, of course, it wasn't used because there wasn't anywhere to bring people.
That's like a friend of mine who's a transportation planner who says you don't determine which rivers need to have a bridge built over them based on how many people currently swim across that river.
Yeah.
Is what that reminds me of.
Yeah, and then I don't know if you're doing CCBHCs in Oregon, but
Starting to.
because the other transportation piece is law enforcement. Like there is most civil commitment law is written that like law enforcement shall do this, shall do that, and like Arizona, we worked to get some of that changed to May so that you could have a clinical transport. But still, like then the question is, well, who pays for it? Because most places see the law enforcement transportation as quote free, and although it's not really free. Oklahoma was very clever in how they use their CCBHC money because the way CCBHC is you generate this needs assessment and then you do
CCBH.
Certified community
behavioral health clinics. It's like an FQHC if you're familiar with that, but for behavioral health.
Peace Health here in Lane County.
It's like an alternative to community mental health centers or another way of funding them.
And the way they're funded is instead of just like billing for stuff, like the state negotiates with CMS and they do a needs assessment of what the need is, and then they also calculate what's the true cost of care for like doing the services that fill the gap in the needs assessment. And they very cleverly included transportation in that. And they were able to pull down new money to do transportation that previously law enforcement was doing. And so now the clinics do it and they get paid for it. And like that's really cool. So I think more states should figure out how they did that and
Smart.
and do that.
Commissioner.
Yeah, just quickly, because I know there's 11 o'clock that some of us want to be on. I'm very impressed and super excited like everybody else. I really appreciate the studies at the end because everybody wants to know if they're putting in all this money and building this building and staffing this operation, that you want to be able to qualify that it's successful. And what does success mean? Does it mean, in my mind right now, it means lower costs to other emergency services. It also means that people are actually getting the care they need. And part of that can be measured by recidivism rates or other means that I am not aware of yet. So I'm very interested as you do more studies on the outcomes, because we need to be able to convey that to the public. We need to show that this facility works, and it works for all these reasons, but mostly because people are getting the care that they need, and hopefully, lowering other services that are extremely costly. My question is, are you able to share this presentation with the City of Eugene and the City of Springfield? Because as our largest municipalities, I think this is critical information for them to share with their city councils.
Happy to share all of that.
I can jump in. The plan that we constructed in trying to use Dr. Balfour's time as efficiently as possible was to have her share with you all and then proactively share the link to this meeting with all of the different municipalities.
I just think you doing this presentation in person with the city councils is going to be far more meaningful than sharing a link to this particular meeting.
I just go where they tell me to go.
Did you tell her to go to Springfield, New Jersey?
And then I have to talk to Brittany.
We did make an attempt to arrange that. As you're aware, the city council meetings are on Monday nights, and Dr. Balfour wasn't able to be here on a Monday night, so it didn't line up. We had offered a work session, and that didn't line up either with the timelines. So we'll continue our efforts as much as possible. I think as we are moving forward with our work to site this facility, there may be an opportunity in the coming months for Dr. Balfour to come and talk with the City of Springfield in particular, and help to make sure that the council really understands this model. And for that audience, maybe also in the context of kind of what the surrounding area looks like when you bring a stabilization center in, because those questions about are people going to be around and not moved on to their next destination have certainly have come up. So I think it's helpful for us to have some education on that.
So happy to come back. Oregon looks lovely. Now that it's daylight.
15 degrees outside.
Currently.
Easy.
Come back, yeah.
Yeah,
Come back
the
with
summer would be
me.
great. Just for the sake of time, just one last comment that I think the public really needs to know from a family who's gone through this crisis and lost a child to suicide on this level. That one statement you said that 60% of the patients involuntarily are eventually converted to voluntary. I think that is a huge statistic that was way overlooked because the crisis that and I was just looking at photos back a few years, just looking at when my son left the house with a suitcase and he was 23 years old, involuntary. There's nothing we could do. No civil commitment laws in Oregon. We could do absolutely nothing as much as we advocated for him. But that statistic alone, if more than half of the patients that are involuntary based on their condition become voluntary, that is a huge win for the community. So I just want to say that impacted me more than anything you said today. So I appreciate that. Thank you very much. Any other comments or questions before we adjourn? Thank you for joining us, Greg Rickoff, for the last bit of this. You got the best part of it. And thank you all for coming. Oh, Commissioner Farr, you have a question up. Go ahead, sir.
Just one final quote from Dr. Ratu to leave us all with, and that is that youth have the experience in an emergency room of being placed in a bare room for days and weeks on end with no stimulation. That underscores the urgency of this work. It underscores the urgency that Springfield and Eugene in our metropolitan area hear these words as soon as possible, so we can get all on the same page. Once again, thank you so much, and I apologize for dragging the meeting on. Can somebody please get Dr. Balfour's autograph for me?
Okay, if there's no further questions or anything, Brittany, thank you very much for your help for doing this, putting this together. Dr. Balfour, thank you for your great information, and the team behind us. Thank you for being such a great pillar of help to all of this, and to Lane County and all the people doing the work. Thank you, Eve, for all of your folks doing work to get this done. We're going to keep going in this direction. So, at sound of my gavel, we will be adjourned. Our next regular County Commissioners meeting is scheduled for Tuesday, February 25th, at 9 a.m. at Harris Hall. We are adjourned.
Thank you all so much for having this.